Alok Sheel to kindly deliver the welcome remarks. But before I do that, allow me to briefly introduce him to you. Dr. Sheel is presently the RBI Chair Professor at ICRIER. He was a member of the Indian Administrative Services for 34 years between 1982 and 2016. During this time, he held several key positions in the Union government as well as in the Kerala state government. In addition to holding positions in the rank of secretary, he had multiple stints in the Treasury departments where he was responsible for budget formulation and management, but also for interface with multilateral financial institutions such as the World Bank, IMF, and UNDP. He was also secretary in Prime Minister's Economic Advisory Council, as well as a senior multilateral interlocutor from the first G20 summit in Washington, D.C. in 2018 to the seventh one in Mexico in 2012. He set up and headed the G20 Secretariat in India and led interdepartmental coordination for participation in various G20 work streams. He was also a part of the Prime Minister's delegation for several G20 summits. Dr. Sheel also has diplomatic experience as an economic counselor in Washington, D.C., and as a chair of the SAARC Development Fund in Bhutan. He has published several articles in books and journals and is a regular commentator on economic issues in the print media, publishing around 200 opinion pieces so far in leading newspapers such as Financial Times London, the Economic Times, the Indian Express, the Financial Express, Business Standard, and the Mint. So with this brief introduction, may I now request Dr. Alok Sheel to kindly deliver the welcome remarks.
Thank you, Ali, and good afternoon, everybody. On behalf of ICRIER and CAS, I'm happy to extend a very warm welcome to all the distinguished speakers and participants of our joint webinar on tackling COVID-19, public health and socioeconomic strategies. The joint series is on COVID-19 global best practices, lessons for and from India. Different countries have adopted a wide range of public health and socioeconomic strategies to tackle the multi-dimensional challenges of the pandemic. In the process, they have drawn from the experience of other countries. This webinar series was launched with the objective of drawing lessons for and as well as from India in tackling the COVID-19 pandemic. There is clearly great scope for countries to learn from each other's strategies and experiences. This will not only help in the short term, but also bolster preparedness over the medium and long term. I am therefore extremely thankful to the Konrad-Adenauer-Stiftung for partnering with us for this and other webinars, to the very distinguished panel of speakers who kindly agreed to share their valuable insights with us, as well as to all participants who have taken time out from their busy schedules to contribute to the discussions. Your participation in today's deliberations would not only enrich the work ICRIER has been doing on these themes, but hopefully attract the attention of relevant policymakers as well. We have an impressive panel of distinguished subject experts who will walk us through critical issues relating to how COVID-19 and similar pandemics in future need to be handled from the public health and socioeconomic points of view. I'm glad that our health research lead, Dr. Ali Mehdi, is coming out with a series of publications on this theme. And we are in fact thinking of a dedicated research program. I will only flag two public health and socioeconomic questions arising from the COVID-19 pandemic. The first issue has to do with the etiology of virus-based diseases. These are inherently difficult to deal with, as viruses are optimized for transmission, mutate rapidly, and are therefore not easy to target through vaccines. The experience so far has been that viruses that are highly infectious are not very deadly, and those that are deadly are not highly infectious. But every now and then, you will have the perfect storm. when a deadly and highly infectious virus comes along, as it did a century ago and has presumably presently. Handling such a pandemic has proved to be a major challenge, even in rich countries with the most developed public health systems. Is it that modern science still has some way to go in learning how to deal with such viral epidemics to prevent high mortality? Also, in these circumstances, do we need differentiated strategies for poorer countries with weaker public health infrastructure? If so, what might these be? The debate centered on how stringent lockdown should be, the levels of fiscal support, the ease of testing, and vaccine availability are possible pointers in this regard. The second issue is to do with mobility and pandemics. Until very recently, humans were relatively immobile, with most people spending their entire life without venturing beyond a few miles of their homes. Human disease and immune systems also tended to be local phenomena. Epidemics were contained locally. This changed with the maritime and later even more fundamentally with the Industrial Revolution that made humans increasingly mobile. The first pandemics, the Justinian plague of the ancient world and the Black Death of the medieval period, were spread through ports by ships. There was high mortality through diseases carried by the Europeans to the New World, against which the local population had no immunity. Mortality actually rose in early industrial Britain because of heightened mobility, till public health interventions led to a decline. The colonial era saw increased human mobility, and with that, new pandemics such as cholera, smallpox, and a number of other diseases carried into interior regions through motorized road and rail transport. The very high mortality of the Spanish flu was not entirely on account of limitations of extant public health infrastructure at the time, but also on account of large-scale troop movements arising from the First World War. With the increasing density of air transport across the globe, pathogens can spread globally within days now. This is what appears to have happened with COVID-19, as governments scrambled to close borders in a disruptive manner that had a devastating impact on the economy and livelihoods. It is only a matter of time before a similar pandemic visits us again. So, what kind of protocols need to be put in place in handling pandemics that are least disruptive for commerce and the economy, that are becoming increasingly globally interconnected? I would like to stop here and invite Mr. Peter Rimmele, the resident representative of the Konrad-Adenauer-Stiftung in India, to kindly share his thoughts with us and set the stage for the thematic session to follow. Before that, allow me to briefly introduce Mr. Rimmele. You will see he has had a very distinguished career. He obtained his first law degree from the University of Freiburg and a second law degree from the Ministry of Justice, also in the German province of Baden-Württemberg. He also has an MA in geography. After working as a jurist, judge, and lecturer, he took public office as ministerial rat, head of division at the State Ministry of the Interior in Saxony between 1991 and 2000. There, he first served in the police and security, and later in the local government department. On behalf of the German Foreign Ministry, he served in East Timor as Registrar General, Head of Civil Registry and Notary Services, and became later the principal advisor for governance reform for GIZ to the Ministry of Administrative Reform and the Anti-Corruption Commission of the Republic of Indonesia, where he served for 7 years. He then moved to Rwanda as the principal advisor under Good Governance Justice Program. And before coming to India, he was CAS resident representative in Lebanon and director of Rule of Law Program for the Middle East and North Africa. As you will see, this is a very distinguished record he has. So ladies and gentlemen, I now have the honor of inviting Mr. Rimmele to deliver his introductory remarks. Over to you, Mr. Rimmele.
Thank you, Dr. Sheel. Good afternoon and a warm welcome to everybody, as well as our deepest gratitude on behalf of CAS and ICRIER to all the distinguished speakers and participants of the ICRIER CAS webinar, Tackling COVID-19, Public Health and Socioeconomic Strategies. Mr. Sheel, thank you very much for your kind introduction. It is our second webinar, the ICRIER CAS webinar series of COVID-19 Global Best Practices, Lessons for, and of course also from India. We are pleased to partner ICRIER again for this timely and essentially important webinar series and take great pride in our continued cooperation. It is very timely. I think the newest figures released yesterday is that the fatality rate is like 400,000 in India. And despite all these grand efforts, only about 15 point something 7, I think, % of the population have received their vaccinations yet. So it is a timely issue to discuss and look how are good practices, how could we improve the situation. In the course of my professional career, you have described it before, I have traveled to vast parts of our verdant planet where I have encountered stories of intense human tragedies and bloody conflicts, countless articles, innumerable news, and a myriad of research pieces and egregious human rights violations throughout these decades, and sometimes even, just a moment, this is switching off. Well, I have to come to just a second. There are technical problems. So I have mentioned that I have done a myriad of research pieces on human rights violations throughout these decades and sometimes even witnessed the aftermath. Example, Rwanda after the genocide there. Too much of exposure to human misery either tends to raise the pain threshold of a person, thus inuring him of these kind of episodes, or motivates a person to feel the pain and try to do something about it. This digital room is full of such motivated people who, on one hand, revel in mitigating the sufferings of humankind, and on the other hand, are very positive in their outlook towards a change in the world in terms of greater equality, fairer working practices, the protection of all humans' rights and dignity, all of which are concerns that are far more important than myself and indeed all of us combined. But nevertheless, I consider myself privileged for being a part of the present company. The second wave of COVID in India has been truly a horrific one. Oxygen cylinders became the new currency in New Delhi, more valuable than all the money in the world, as the possession could decide over the life or death of a loved one. Hospitals had to tell family members that their beloved's life rested in their own hands, as there were no vacant beds left. And for those for whom all help came too late, a dignified burial within the family circle turned into an unavailable right. We just look back to April and May. That was the situation. Nearly all of us have witnessed individual human tragedies in this past month, disrupted families, the loss of life, or young, healthy members of our communities on a scale that is very hard to cope with and even comprehend till today. The COVID-19 pandemic has highlighted the system risk posed by the global health crisis, the potential for disruption of routine operations of health systems, and the wide-ranging impact of socioeconomic outcomes. Globally, 181 million confirmed cases and 3.9 million COVID-related deaths. The share of India I have just mentioned, and that was only the official figure, as we know. The non-reported cases must be still quite high. So this number has been reported to the World Health Organization until 28th of June. Of these 3.9 million deaths, 3.1 million have been reported from the Americas, 1.9 million in Europe, and 1.2 alone. Asia and Africa seem to have done much better vis-a-vis the developed world in this regard. And as just mentioned before, there is much better health systems in the developed world, and it seems it hasn't changed it there. According to the Johns Hopkins University, almost 4 million people have died worldwide since the pandemic began. The number of unreported deaths is by far higher. That is not only in India the case. Sometimes we tend to forget that behind these statistics, their destinies, hopes, aspirations, that they are people, that there is life, and they are not just numbers. As the German journalist Kurt Tucholsky once cynically remarked, if only one person dies, it is a tragedy. When millions die, it's only a statistic. When we last met on 27th of April for the first episode of our webinar series on tackling COVID-19, the panelist, Mr. Anand Krishnan, observed that we tend not to learn from the past. The German philosopher Hegel once said, the only thing we learn from history, that we learn nothing from history. Yet, ladies and gentlemen, what we have witnessed over the last almost 2 years around the world, and especially over the last few months in India, leaves us with no option but to learn from history, as we can no longer morally or politically justify leaving our healthcare workers all alone on the front lines, risking their own lives. And I just saw a photo of nurses in Assam, I think, who were commemorating all the doctors who have died of COVID in there. So we can no longer have our healthcare workers all alone on the front lines to fight this battle, inadequately equipped and vastly undermanned against the invisible enemy called COVID-19, or any other such microorganism that can heap an avalanche of misery in future, and which may even, and this is of course very speculative, but it's discussed, which may even have been weaponized by a country nursing ambitions of being a global hegemon. That said, allow me to reflect on the positive lessons I personally believe we have actually learned from this ongoing pandemic. First, and probably most important, the rapid development of vaccines has reminded us of the importance of multilateral cooperation between our nations and not closing the borders as it has been said in the beginning. It has taught us that we can bring scientists from all fields together in new and creative collaborations and handle things much more quickly than we would have thought previously. Secondly, and here I'm referring to the vast majority of nations of our world, the pandemic has mercilessly exposed many fundamental problems that we have long known to exist, in particular health inequalities and the continued disinvestment in our public health systems. Addressing these problems, as well as continued commitment to address them in the long term, will show whether we have truly learned our lesson or failed to do so. For the sake of our future generations, I hope we will be able to answer this question positively in the years to come. And finally, COVID-19 has shown us how unprepared we are for such a global pandemic at the local, national, and global levels. Moreover, it's also revealed how vital it is to have clear, timely, and transparent communication when responding to a pandemic. By the time we responded during this pandemic, it was often too late. And even though many of our current biggest health challenges are quite different from COVID-19, such as diabetes or heart diseases, the same principle of being diligently prepared applies here. Let me conclude, ladies and gentlemen. I would like to share with you a Tibetan proverb that goes as follows. Tragedy should be used as a source of strength, no matter what kind of difficulty, how painful the experience, when we lose hope that it is our real disaster. I'm confident that today's panelists will be able to provide us with several key positive insights and strategies for public health and the socioeconomic realm that aid in restoring hope in all of us that united we will be able to successfully overcome this deadly virus. So let's have this hope and not give it up. Thank you very much.
Thank you very much, Mr. Rimmele, for these very inspiring and insightful remarks. And thank you, Dr. Alok, also for your welcome remarks, which have set the stage for discussions with an extraordinary panel of speakers during this thematic session, which I have the honor of chairing. There are basically three questions that we are going to focus on during this thematic session. Number one, what have been the key public health and socioeconomic strategies adopted by countries to tackle the COVID-19 pandemic? Number two, how has evidence been leveraged and how have the responses to the pandemic evolved with the unfolding evidence? Because since you're dealing with a novel mutating virus, sound evidence has to be the cornerstone of all our strategies in dealing with it. And finally, what are the lessons for as well as from developing countries like India in terms of tackling the pandemic? This is a crucial question given the disastrous second wave that we have witnessed in this country, as well as the re-emergence of waves in other parts of the world. And I really hope that this webinar will be able to offer some lessons at least towards better pandemic preparedness in India, as well as elsewhere for the future. So ladies and gentlemen, let me not keep you any further from what our distinguished panel of speakers have to say. But before I invite our first speaker, let me just mention that the discussion that we're going to have today will be captured in a policy brief that we will develop after this webinar. We will make sure that this policy brief reaches all of you as well as other health sector stakeholders, especially policymakers. Let me also request the distinguished participants of the webinar to feel free to add their brief and focused comments and suggestions in the Zoom chat box. And for those who have logged in through the YouTube, to kindly do so in the YouTube comment section. And I'll be happy to take them after all the speakers have presented. So let me now move on to inviting Professor Sakthivel Selvaraj to share his views with us. Professor Selvaraj currently holds the position of Director, Health Economics, Financing and Policy at the illustrious Public Health Foundation of India, the PHFI. He has made significant contributions to the development of the high-level expert group report on universal health coverage for India, instituted by the erstwhile Planning Commission. He also contributed immensely to the development of the state health policy for the state of Uttar Pradesh, which is the largest state in India. Previously, he has also been involved with the National Commission on Macroeconomics and Health, and has also been the founder secretary of the Indian Health Economics Association. In his presentation, Professor Selvaraj will focus on the past and current health financing responses in the overall health system, especially with reference to COVID-19. While doing so, he will touch upon several facets of health financing, health insurance, households' financial burden, poor price regulation of hospitals and drugs, irrational consumption of medicines and supplies, as well as vaccine strategies. With this introduction, I'm honored to invite Professor Selvaraj to kindly share his views with us. Professor Selvaraj, over to you.
I'm just trying to share these slides, I hope. Is this visible now to everyone?
Yeah, we can see it. But we can't see the full slide on the right side.
I guess I can't see for myself. Okay, now I'm not sure. Can you see this now, Dr. Ali Mehdi?
No, we can't. We can't see the slides.
I can see the slides here.
Earlier we could see it partially, but now it's not visible at all.
All right. I sent you my slides a little early.
Yeah. Should I put it up? Should I put it up?
Yeah,
You can.
Looks like there's a bit of a challenge from other side.
Okay, let me open it, and then you can let me know if whenever you want me to change it. Is the PPT visible now to everyone?
Yes, we can see it.
Yes, we can see it.
Okay, great.
Thank you so much.
You're most welcome.
For putting this up. Thank you, Dr. Ali, for that short introduction. And good afternoon, everyone. Respected panelists. It's a pleasure and honor to join this webinar. At the outset, I wanted to thank ICRIER for inviting me to share some of my thoughts in emerging evidence around the health system response to COVID in India. So largely, my theme of today's webinar is going to be largely around the health system response to India's COVID-19. What I intend to do in the next about 15-20 minutes is to talk about the challenges that we've been facing in the last about one and a half year during the pandemic. And then finally, towards the end, I'll try and organize my thought in terms of what could be the possible solutions, largely around the medium and long-term solutions for the Indian health system to become resilient and strong. I mean, that's essentially what I'm going to be doing in the next about 25 minutes or so. Okay, can we move on to the first slide, please? All right, let me start, in fact, by arguing that India's current health system fault lines were actually laid 30 years ago with economic liberalization, giving primacy to market and private participation. In fact, what we witnessed today during the pandemic is that fault line are actually amplified and a result of a gross neglect of public health care delivery in the country and a vicious promotion of the private health care services. Now, let me pick up 5 or 6 points. First, I think in terms of the current challenges that we're facing is India's health system is predominantly private oriented. When I say that because of the fact that both in terms of the financing and provision of healthcare services, I can't think of any country for that matter, not even US or some of the other countries, where both healthcare financing as well as healthcare delivery is private dominated. For most of you, for some of you may not be aware of the fact that the Indian system is highly privatized for the simple reason that in terms of financing, almost more than 60%, almost 2/3 of the funding comes from households. That's essentially privately funded health system. I can't think of any other country in the world. Although private, even in terms of the private delivery of, delivery of healthcare services, almost 70% of outpatient visits and about 60% of the hospitalization episodes in India happens in the private sector. So largely, this is a very privately dominated health system that India has and has built in the last about 70 years or so, especially in the last 30 years. The second point, which flows from the first point, is about, again, I can't think of any country, maybe we can only compare it with some of the sub-Saharan African countries in terms of the spending, public spending. Currently, India spends about 4% of its GDP on healthcare. But if you look at, as I said earlier, if you look at the spending pattern, 60%, as I said, actually comes from the households. The obvious result of this high households out-of-pocket payment is the fact that about 60 million people in India annually are medically impoverished, and about 100 million people incur what is called catastrophic payment due to medical illnesses. So this is something that I can't think of any other parallel to any country in terms of the magnitude of this kind of spending and then the impact it has. The third point is about the way our country's health system is structured, especially in the given the federal nature of our country. Traditionally, the tussle that goes on between the central and the state governments in terms of role of health has been a protracted one, as most of you would understand. Although the Indian Constitution mandated certain functions such as medical education, drug regulation, and public health, but the states continue to carry out the other functions in terms of implementation of the programs of the central government and implementing its own plans and programs. But the problem is the lines dividing these functions have blurred over the years. Many of you would know that states are fiscally challenged. They struggle to really find resources to spend for health. The center abdicated its responsibility by promoting and pointing out that health is a state subject. So if you really look at, for instance, the national health policy in India, which you can see in 1983, the first policy, 2002, second policy, and then 2017, the latest policy. To implement them in letter and spirit. I mean, that's a essential problem with this whole, and the flip-flop that continues between the center and the states, leaving citizens to fend for themselves, and historically low commitment of the governments to healthcare continues until today. The fourth problem, of course, is to do with the informalization of the labor force. At least, if not informalization, at least there's a huge formalization of workforce is stagnant for the past 20, 30 years. And why do I say that it's important, relevant in this context is the fact that any attempt at enlarging the scope of social health insurance will be limited because by the ever increasing informalization of the workforce. I mean, that's the larger problem that the health system also faces. And of course, the fifth issue is to do with India's budgetary system, which remains rigid and leaving little room for innovation and flexibility in resource. More of a setting stage to understand the current challenges India faces. Let me move on to the next slide. In terms of the pandemic and then the lockdown the first set of national lockdown last year, and then several state level lockdown that's happening currently, although some states have lifted some of these restrictions. The point to note about the lockdowns, the national lockdown last year and as well as this year, the substantial impact of the lockdown, both in terms of the socioeconomic consequences as well as health system challenges, should be understood. And we know that India faces an unprecedented negative economic growth for the first time in India's independence. It's incalculable job and wage losses is something that we all know, besides the social disruption among families. And in fact, the second wave and the associated restrictions are likely to even further exacerbate the socioeconomic performance of the country. So can we move on to the third slide, please? In terms of, in fact, interestingly, from the point of view of the health system, actually the lockdown impact on the health system ranges from demand-driven and supply-side disruptions of health services. Now, we know from several evidence that hospital activity, which is basically a supply-side indicator, dropped sharply during and even after the lockdown was lifted. And service utilization, for instance, which is an indicator of a demand-side indicator, fell substantially to about anywhere between 42 to 61% during and after the lockdown. Interestingly, you might even notice that even several non-emergency services, including TB, malaria, HIV, testing and treatment of those services and prevention activities were severely stalled. What we also know is that a sizable decline in immunization coverage is happening from the field level data, and a sharp increase in home-based childbirths. Now, these are things which otherwise In fact, for instance, the home-based childbirth was just about 10% before the COVID times. And there is an apprehension that the home-based childbirth care has actually gone up in a large way. So these are just to give an idea about the kind of outcomes that one can really witness during and after the lockdowns and even during the COVID time period in large. Can we move on to the next slide, please? Although the first lockdown was essentially intended to delay the onset of large-scale infections and ideally prepare the health system to take on the extra load from the pandemic, I think the second lockdown, mostly which is followed in states, was forced by an unprecedented surge in infections. I think the surge was caused by big-time gatherings of the population, something that we all know in election meetings and religious congregations and cricket matches and whatnot. The health system response was too little and too late. And we know that poor planning, weak response, regulatory failure, and a deep belief in market system actually wreaked havoc. So the point about the harrowing tales of people gasping for breath due to oxygen shortages, searching desperately for scarce life-saving medicines and looking for an elusive bed in hospitals, they all have put Indians insecure and traumatized. So what was the health system finance response? Can we move on to the next slide, please? So did we really respond? Did the health system, especially the government health system, did respond well? Now look at what's happening to the health financing response. Look at this, both the central and state 21-22. And interestingly, this is just pre-COVID levels. If you leave out the national government, for instance, the national government spending is the only exception. In fact, this was partly due to extra spending, which is a one-time extra spending on vaccination, which is going to be worth about 350,000 million, and about 140,000 million will be made available, possible by extra spending on account of the 15th Finance Commission recommendations. So it's equally likely that the central government may front load some of the allocation meant for the rest of the 4 years of tax devolution from the center to the states. Now, that seems to be the only silver lining in terms of spending on health during the pandemic. So that's last year, as well as the planned spending for 21-22 as well. So that's in terms of the first health system response and in terms of healthcare financing response. Can we move on to the next slide, please? So people might argue that, all right, so that's your typical treasury route funding. People, of course, talk a lot about the health insurance in India. Now, for some of you who are not aware of the health insurance stories in India, I think I must say that the development and the performance of the health, in fact, the health insurance story in India is unprecedented in terms of the speed in which the coverage was extended the last about 15 years or so. So although health insurance as a tool is expected to absorb the health shock, but the pandemic is supposed to be a testing time for these plans, these health insurance plans. Well, broadly, India has 3 sets of health insurance schemes. We know that there is a tax-funded health insurance schemes. That's typically the Prime Minister's Jan Arogya Yojana, which is basically the tax-funded health insurance scheme. The entire premiums are paid by the government, both the center and the states. And there is a social health insurance scheme, which is basically which is largely the ESIS and then the CGHS, supposed to be funded by the employers and employees, to some extent government. But as far as CGHS is concerned, it's largely the premiums are paid by the government and a little bit of premium paid by the central government employees. And the third set of insurance in India that we have is the private health insurance scheme. Now, if you look at all the 3 sets of schemes, and I've got 5 there, it currently covers about 900 million people. So that's from about 70 million about 15 years ago. Look at the speed and the magnitude of coverage from about 70 million 15 years ago, right now, India covers about 900 million people with some health insurance. Roughly, that's about 2 in 3 persons in India are covered by any health insurance schemes. But these are all nominal coverage. These are all nominal coverage because the effective coverage is at best limited to just about 1/5 of the population. So if you look at several sample surveys, whether it is a national sample survey or the NFHS, it very clearly shows that the effective coverage is just about 20 to 25%. So that's something that we need to really recognize, especially in the context of narrative around health insurance that people talk about. Can we move on to the next slide, please? So although in terms of health insurance, population coverage is very high, as I said, about close to about 900 million people covered. But in terms of the service coverage, ESIs and CGHS are perhaps one of the most generous coverage it provides. But PMJ and the private health insurance plans, largely they provide hospitalization. The cost coverage, however, is very limited in this particular scheme. PMJ's current premium is just about 130 rupees against 10,000 rupees per beneficiary in CGHS. See the large, vast difference between these two schemes, while private health insurance premium is just about 4,481 per beneficiary. Now, why do I say that? The reason for bringing this up is that despite these costs, households still do end up paying a huge amount of money because these schemes and plans do not really provide comprehensive coverage, unlike the only the exception being ESIS and to some extent CGHS. As I said, ESIS, for instance, which covers about 130 million people, provides a comprehensive coverage of inpatient, outpatient, preventive care services, even sickness benefit, and people who are sick during certain time period are also given provided wage compensation. So if you leave ESIS out, the rest of the insurance schemes are really at best very, very limited in terms of cost coverage. That's a point that one must bring in. Can we move on to the next slide, please? Having said that, now the point is, although PMJ, as I said, covers about 650 million people, but unfortunately, if you look at the PMJ performance last year and until June this year, just about less than 0.5% of the total COVID test in India was actually covered by PMJ, and about 12 to 13% of all the hospitalization in India was covered by PMJ schemes. So essentially, the point that I'm trying to drive home is that these coverages are very, very limited in a sense. And also the fact that if you also realize the fact that these sets of insurance schemes focus largely around hospitalization. But if you look at the households out-of-pocket payment, a large part of the households out-of-pocket payment goes for outpatient care treatment, especially for medicines buying. That's something that I'll turn to in the next slides. But before I do that, can I go back? Our own evidence from the PLFS suggests that what if a particular person is hospitalized? Now, how much of, given the fact that ICU hospitalization for COVID is extremely expensive, we did a simple calculation of how does it cost in terms of each of those the worker categories. Now, to our horror, we find that a particular casual worker would take about 471 days just to pay off one episode of ICU hospitalization, right? And about 312 days, even for a self-employed, it will take about 370 days for one episode of hospitalization. And even for a regular employee, it's going to take about 60% of their wage for an episode of a hospitalization. So what we really found was that 86% of our casual workers in India just simply cannot afford to pay for ICU hospitalization, and about 66% of them just simply cannot, the self-employed cannot pay for ICU hospitalization. Even half of the salaried employees just simply cannot pay for ICU hospitalization. Our own estimates, again, back of the envelope calculation shows that the total, if you look at the total expenditure, both for the government and for the households, our own estimates suggest that the second wave, which is just about 3 months, if you're beginning from April to June, just the total expenditure, both for the government and households, actually exceeds, if you put together the entire spending, total expenditure of last year for COVID. So I looked at the kind of magnitude of the financial strain on population. And that's the point that I want to drive home. Let me on to next slide, please. The second point, in addition to the point about that I talked in terms of the financial vulnerability, the other vulnerability that can also be looked at, and not really, in fact, it's also a vulnerability as well as there is a huge problem with the consumption aspect. Now, India, interestingly, as you can see, spent a huge, the last about 1.5 years, we've been tracking the way medicine consumption is happening in this country. Huge inappropriate consumption. Indians spent about 150, so about 115,000 crore worth of medicines on immunity boosters alone. So vitamins, minerals, and supplements, which in many circumstances clinically not really appropriate. But we went on consuming most of them. And we also observed the huge overuse of antibiotics and antivirals, which has been reported. And of course, unnecessary use of corticosteroids, which is creating a lot of other repercussions, which many of you have been tracking through the media, I guess. I wouldn't really go into further on this. Can I move on to the next slide, please? And this is even more interesting, that the drug shortage that has happened is even more problematic, because in a country which boasts of being the global pharmacy, we did find a huge shortage of drugs. I'll just take one simple example, remdesivir, which is an antiviral. Most of you are now aware of the media reports. Actually, remdesivir currently is basically a conditional, which is only provided conditional recommendation to WHO. It's currently sold in the range of, I mean, in the market, in the black market, sold at about anywhere between 8,000 to 80,000 per vial in the open market at the peak of the pandemic. Something that many of us know. A patient actually would need to pay about anywhere between 4 to 5 lakhs for a 5 to 7 days of treatment just for a drug that was only investigational in nature. So even actually the cheapest selling drug of the remdesivir is supposed to be 900 rupees MRP for 100 mg vial of remdesivir. Actually, if you look at the production cost, it's actually just indefensible, the kind of market prices that went on. The actual cost of production is just about 70 rupees per vial, but it is sold with an MRP rate of about 900. But you and I know that in the market, especially in the black market, it used to be sold anywhere between 8,000 to 80,000 per vial, per 100 mg vial of remdesivir. And that's the kind of a market that we had without much of a regulation. And that's the point that I wanted to drive home. So our regulation really failed miserably in a big way. Okay, let me move on to the next point about the other solution. Interestingly, we also see that if you look at the market, ideally, the government should have invoked several provisions of the TRIPS flexibilities to bring in those medicines and vaccines into market by simply providing a compulsory licensing. Unfortunately, we don't see that. and it seems to be still waiting for a WTO waiver, which seems to be far away. I guess by the time the pandemic will be over, hopefully. But what's really happening within the market is, if you look at the market, in fact, today is interestingly, the Economic Times provides a very useful, interesting glimpse of what's really happening. Look at the 5 interesting, these are all top selling, some of the top sellings, not all of them, but some of the top selling drug currently is all has voluntary licensing. Voluntary licensing with some of these Indian companies. Remember, the problem with voluntary licensing is it's a suboptimal solution. It doesn't really provide you a good competition. You're only creating a bit of a oligopoly within the market, which has implications both for the market competition as well as for prices. And that's a simple point that I wanted to bring home. So the point is we need multiple response. So for instance, in this case, we need 2 sets of responses, one from the competition commission, the competition regulator, who should have looked at the voluntary licensing aspect, and 2, the government of India should have invoked by now the compulsory licensing using the TRIPS flexibilities. So the point is, we need to look at different options rather than getting bogged down to some of these strategic issues. Can we move on to the next slide, please? Okay. The other point is about vaccine financing, procurement, distribution. I wouldn't really, given the fact that we're already running late, I just simply wanted to bring home the fact that now vaccine financing, procurement, distribution is extremely important. Unfortunately, for a long time, the point we need to realize is that vaccine, unlike other service delivery of commodities, vaccine is basically a global public good with huge positive externalities. Now, we can't simply create different market for vaccines, one for the rich and one for the non-rich, because the moment you do it, affordability question is simply not an issue here. The question is to how do we prevent infections? So obviously it's a global public good. We need to recognize the fact that it is a global public good and accordingly have to be financed and procured, especially by the government, which I think now finally the government has agreed to do this and distributed locally by the state government. I wouldn't really, given the time constraint, I'm really not going to go into the other aspects of it. Let me quickly move on to the last few slides. Can we move on to the last slide, perhaps the last slide? We'll try and, yes, the last slide. No, before that. Yes. So let me try and wrap up my quick thoughts in terms of how does one go about reshaping the health system and make it more resilient, given the fact that we have the pandemic is still on, and so the question is, how do we make the health system strong and resilient? Something that's we are all familiar currently, as I said, India just spends 1% of its GDP on healthcare, public spending. I think there is an urgent need to accelerate public spending to at least about 2.5 to 3%, and this should ideally be tax funded, complemented by wage contribution from employer and employee. But largely, given the fact that we still have a huge 90% informal workforce, the only option is tax-funded money that should go into funding public, robust and resilient public health system. In fact, in addition to accelerating the public health financing, we also need to try and avoid fragmentation of healthcare financing system. There is a need for integrating a lot of these insurance schemes into one or two such schemes so that scale economies can be arrived at, cost minimization can be achieved, and we can leverage this to get a larger coverage. So that's in terms of the financing. In terms of the access to medicine, my simple point is we need to increase government spending on medicines, and then also improve procurement and supply chain. So this is hardly done in many states, except 4 or 5 states. The drug procurement and supply chain is absolutely miserably absent in many of these states. So in addition, I think regulation is very key to making good quality medicines which are supplied for the population. In addition, the other important point is that the standard treatment guidelines should be the norm for clinical drug prescription and dispensing. The reason why I'm saying is that, as I said, the last one and a half years, we've seen a huge inappropriate consumption of medicines, which can have huge impact in terms of the looming antibiotics resistance. And that kind of a crisis we need to avoid. We already have a crisis at hand. We can't afford to have another crisis in the name of antibiotic resistance. Of course, there is a need to make TRIPS provisions more to ensure access and affordability of key medicines. The other point is about people ended up paying a lot of money for hospitalization, and even otherwise, there is an urgent need to implement clinical establishment and act and rules in order to regulate the private sector, both for quality and price. As far as the government system is concerned, I think there's a crying need to improve the quality in government health services. Well, if the pandemic were to prolong, I think it's going to place a significant strain on non-COVID services, considerably affecting the coverage of health services. Let me stop here by saying that I think the need for universalizing the healthcare in India is far more urgent than ever, with a focus, of course, on preventive and promotive care delivered largely by healthcare system. I'll stop there. Thank you, everyone.
Thank you so much, Professor Selvaraj, for a very enlightening presentation, highlighting the need for a whole of government approach, especially in the context of low allocation to healthcare on the part of the governments, both central and state, as well as the low affordability on the part of a vast majority of people, and the lack of depth of universal healthcare. And I really like the point, your last point about not just expanding the UHC cube as the WHO calls it, but also focusing on preventive and promotive aspects of healthcare. Because I think universal healthcare is very widely misunderstood in terms of curative care. There is a strong element of preventive and promotive care also that also needs to be universalized as part of universal healthcare. So we have a very, several very distinguished speakers. I'm not going to take too much time on my part. Thank you, Professor Selvaraj, once again. I now have the privilege of inviting Dr. Peter Taylor to share his views with us. Dr. Taylor is the Director of Research at the acclaimed Institute of Development Studies, IDS, in the UK. During 30 years of his experience in international development, Dr. Taylor has worked at IDRC Canada for more than a decade, for more than 6 years at the IDS earlier between 2003 and 2009. He has also been a technical advisor at Helvetus for more than 3 years, as well as a lecturer at the University of Reading for more than 5 years, and a teacher at a Botswana Community College for 4 years. I personally have had the honor of working with Dr. Taylor for 2 G20 policy briefs on health, one during the German presidency in 2017, and one recently during the ongoing Italian presidency. And I'm really looking forward to working with him on this as well as other themes in the future. Today, Dr. Taylor will talk about addressing inequalities in the era of COVID-19 and the need for leadership, partnership, and evidence. As part of his presentation, he will talk about how COVID-19 is shining a spotlight on a range of fissures, cracks, and marginalizations in societies throughout the world. Although the pandemic is frequently characterized as a health crisis, it is in fact multidimensional in nature and is heightening fragilities, exacerbating inequalities, and deepening vulnerabilities in systems of all kinds. For improvements in development outcomes in the short, medium, and longer terms, we will need to focus efforts, so argues Dr. Taylor, on building the resilience of systems overall, as well as that of communities, if transformational progress is to be achieved. This all sounds very fascinating, Dr. Taylor, and we can't wait to hear from you. So over to you now.
Thank you very much, Ali. And firstly, many thanks to ICRIER and the Konrad-Adenauer-Stiftung, and particularly to Dr. Ali Mehdi for inviting me to participate in this event alongside such a distinguished panel. It was fascinating to see Professor Selvaraj's presentation just now. I hope that those slides may be made available for us afterwards to take a closer look, because there's a fabulous array of data and evidence there. And my presentation is probably going to be at a little bit of a different level of discussion, but it's hopefully underpinned by quite a body of evidence and emerging data, which certainly at the Institute of Development Studies we're trying to bring together, and I'd be happy to share more information about that afterwards if participants are interested. So I'd just like to begin with the observation, now made increasingly by a number of others, that COVID-19 is really shining a spotlight, bringing into sharp relief a range of fissures, cracks, and marginalizations in societies throughout the world. And the pandemic is still frequently characterized as a health crisis, which it is, but it's also multidimensional. And we know that it's heightening fragilities, it's exacerbating inequalities, and it's deepening vulnerabilities in systems of all kinds. Just a few weeks ago, the Independent Panel for Pandemic Preparedness and Response released a report entitled COVID-19, Make It the Last Pandemic. And the report observes inequality has been the determining factor explaining why the COVID-19 pandemic has had such differential impacts on people's lives and livelihoods. Now, these challenges of inequality are universal. They're felt everywhere, including here in the UK, where I'm speaking from now, but they're also felt in low and middle income countries where people are really suffering a huge amount, as we've heard in the last presentation, and also suffering differentially, whether that's because of gender, age, or poverty, or other factors. So in this quick 15-minute presentation, I'd like to talk about three main points. Firstly, why, if we're going to build forward differently, we'll need stronger, more resilient health systems. And then second, an example of a current debate, which is very prevalent here in the UK and in Europe at the moment, about a response to the pandemic, which I think demonstrates why leadership, partnership, and evidence are really needed if we're serious about addressing inequalities. And that's the question of vaccine certification. And third, a few suggested ways forward, which might help us collectively to think about how to move along these transformative pathways. So first, health systems. And a recent collaboration with Dr. Ali Mehdi, as he mentioned, and other colleagues in preparing a T20 policy brief on pandemic preparedness and the need to strengthen health systems, highlighted that improving quality, coverage, and resilience of healthcare is of primary importance if we want to sustain long-term socioeconomic progress in countries promoting shared prosperity, whilst also driving sustainable and inclusive growth. And we've all seen over the past year how the COVID-19 pandemic has highlighted the systemic risk posed by global health crises, the potential for disruption of routine operations of health systems, and also their wide-ranging effect on economic and societal outcomes, again, as these points were raised in the last presentation. And evidence shows that healthcare services vary greatly across countries. And of course, they involve different models, types of arrangement, levels of development. And these arrangements are also influenced by the kinds of health threats and problems that are present in the immediate context where those health systems are located. And the evidence tells us a great deal about global inequalities. It shows that at least half of the world's population do not have full coverage of essential health services, and around 12% of the world's population spend at least 10% of their household budgets on healthcare. And universal health coverage, again, as we just heard, remains an ambition, and outside most high-income countries, nowhere near a reality for millions of people around the world whose lives have actually been made worse by the setbacks of COVID. And the pandemic has demonstrated that not only those health systems perceived as weak are struggling, many health systems that are relatively well-funded and are considered stronger, including where I live in the UK, have also struggled to respond quickly and effectively. And although genuine progress is made for periods of time, we all know, especially recently in India, how easily disrupted that progress is by the emergence and spread of new COVID variants. And although this is a recurrence of coronavirus of animal origin to have caused an outbreak of epidemic proportions this century, many countries across the world simply did not acknowledge the importance of previous experiences in fighting epidemics. And overall, we've seen complacency when the first signs of the virus appeared, coupled with a lack of leadership and a failure to adequately prepare until the spread of the virus and its impacts have become all too apparent. So we can safely say that all health systems in all contexts have proven unprepared to meet the challenge of COVID-19. And the pandemic has rapidly overwhelmed their outbreak response capacities, and it's severely affected the supply and the demand of essential care. and this resulted in increasing morbidity and huge mortality rates. And at an international level, the pandemic has also unveiled significant weaknesses in the harmonization of policies and health practices, even among wealthier countries, including the G20 members. Nations around the world have exhibited a lack of coordination in information exchange, in procurement of health equipment and medicines, and this has made it difficult to mount a concerted effort to deal with the pandemic. And the same lack of global coordination is currently affecting the rollout and distribution of vaccines. So in the years to come, we anticipate this challenge of epidemics and pandemics will remain, and it may grow even more critical. We see the effects of environmental degradation. The connected risk of new zoonotic diseases and demographic trends are likely to increase pressures on health systems across the world. And if we want to see Sustainable Development Goal 3 of ensuring healthy lives and promote well-being for all at all ages really being achieved, it's going to be necessary to increase the preparedness capabilities and the resilience of health systems. And this is going to require whole of government and whole of society approaches. So to my second point, a current debate over a particular pandemic response. And the global focus on recovery from the COVID-19 pandemic has shifted a great deal of attention to vaccines, their availability, their rollout, and their take-up. We know distribution is complex, and we know that there are significant inequalities associated with who gets the vaccine, where, and why, as we've heard in this panel, also in the context of India. And in countries such as the UK, where vaccine rollout is progressing rapidly, and by and large successfully, this is mainly due to centralizing the way in which this has been coordinated and managed through the National Health Service. And it's also been coupled with a huge outreach program across the whole of society in the UK. But there are now new questions emerging, of course, about making vaccines available to countries who urgently need them, how to identify who has been vaccinated, and the contentious question of whether it's time to introduce what we're terming vaccine passports. So using certification to demonstrate that a person has had the COVID-19 vaccine can be seen as an attractive way to bring society back to normality by allowing travel and movement both internationally and domestically. It can be used to enable people to be free to attend public events. Just now we're seeing this being tested out, for example, with the Euro football competitions, which are actually inviting almost capacity crowds back into public spaces, which seems almost incredible given what's happened in the last year. It might even extend to the right to be able to carry out certain employment tasks. But this idea of vaccine passports as part of a roadmap to return to some kind of normality also raises major concerns about inequalities. And it's clear that we need more evidence about whether viral transmission is possible by those who've been vaccinated. We know that there are breakthrough cases where individuals are still testing positive for COVID even after receiving 2 doses of the vaccine. And we can't develop some form of certification and isolation from other measures. It will only be effective if it works in secure and reliable ways within and across nations. And it raises significant challenges for digital data security, privacy, security, and trust. And this really has the potential to further accelerate inequalities in the UK, in specific countries, and globally. And as we've seen in so many contexts around the world, the pandemic has already exacerbated these existing inequalities, as have many of the measures taken to try to mitigate its impact. So there's a real danger from hasty introduction of vaccine passports as a political knee-jerk reaction. It could actually generate far more harm than good by entrenching vulnerabilities and precarities that many people currently experience. For example, by removing the rights of certain groups of people to work and earn a living because they don't have access to the vaccine or they're not availing of it for justifiable reasons. And there's a risk that in many global contexts, vaccine passports could actually worsen economic conditions by shutting large groups of people out from the formal economy. So there's justifiable concern that the introduction of vaccine passports could reduce trust and increase vaccine hesitancy. And for marginalized groups, there's a risk that vaccine passports could be seen as introducing mandatory vaccination by the back door. It could worsen inequalities within societies where there's existing distrust of the state, identity, infrastructure, and limited access to vaccines are expected to put some groups at a particular disadvantage. And there's also a danger that this type of intervention might further increase inequalities between nations. We know that international cooperation in tackling the pandemic's impact is necessary, and we're going to see this increasingly as the demand for international travel starts to increase. And there's pressure on governments to acquire vaccine supplies, which in turn triggers a form of vaccine nationalism, as we know, where richer countries are buying up supplies of vaccines where poorer ones can't. So this idea of some form of certification or passport for vaccination is attractive, but there really needs to be a whole of society approach, which includes public consultation and including deliberation on how health data relating to COVID-19 and vaccines is being used. And it really requires engagement and partnership with civil society, including experts in data ethics, with a view to the long-term implications of schemes such as this, particularly for groups that are disadvantaged and vulnerable. And it seems inevitable, it's already being rolled out in the UK, but I would argue that the way these schemes are used needs to step beyond political interests and the influence of the loudest voices in what's bound to be an intense public debate, as I'm sure it's going to be in India in the coming months. And an important move like this is bound to need sufficient time, careful consideration, and consultation. So thirdly and finally, a few thoughts about actions which may be needed if we're serious about addressing the inequalities which have been thrown into even harsher relief by the spotlight of COVID-19. So firstly, we clearly need to respond with urgency to the crisis. We need to tailor our actions to meet the needs of those who are most vulnerable and the greatest danger of being left behind. We're going to need multi-pronged approaches to addressing challenges around food, social protection, gender equality, governance, and a range of other societal issues. And we need to combine immediate responses to vulnerabilities while we're also looking to the future and investing in long-term transformations which are evidence-based. We're going to need leadership because we need to challenge complacency. We need to tackle tacit acceptance of inequalities, especially those who are less visible and where the voices of those who experience those inequalities are still unheard. We also need to help people be better prepared for the future. And to be able to address new and different shocks, which are almost inevitable, we need to build slack into systems and institutions which can be drawn upon in times of crisis. And we've seen the challenge of ultra lean systems, which are driven by efficiency models, are really demonstrating a lack of resilience to respond. We need partnerships to work together, joining up our efforts and collaborating, whether it's to transform development, economies, communities, and people's lives. And although the pandemic has presented many challenges for those working remotely, this event is possible because ICRIER has facilitated it, and I'm able to join you all here from the UK. And that provides us with useful opportunities to engage. But also, we have to recognize that not everyone has access to these vehicles and to these platforms. And we're going to need different perspectives because this is a complex challenge going forward, especially complementing medical sciences with social sciences and engaging with citizens. And finally, to do all of this, I would just end by saying that I think we have to really examine ourselves and ask ourselves, how do we transform ourselves as individuals and the institutions that shape so much of our lives? There's a great deal of discussion about building back better, or perhaps reframing it as building forward differently. And I would say that's a long-term mission. It's going to require us to understand and act upon the deep structural inequalities in societies, within countries, and between countries. And it will require interventions that include but go beyond health. It's going to involve really strong coordination, information flows, and lesson learning. And it's going to need commitment, including political commitment, because we're going to need the energy, the resources, and a truly joined up collaborative effort if aspirations are to become a reality. Thank you very much.
Thank you so much, Peter. It's really very enlightening to hear your views, and thank you for sharing how we can collectively and equitably shape and even transform the shared future, and what steps are necessary for us to do so. I think your point about the pandemic being multidimensional in nature, and the need for going beyond the health sector and looking at the marginalizations at various levels to deal with the impact of the pandemic is, I think, not relevant for any country more than it is for India. So, given our cross-cutting inequalities and challenges that we face in this country. So thank you so much for highlighting those issues, and we will ensure that all these issues are adequately reflected in our policy brief. So thank you once again. So our next speaker, Dr. Juliane Fluck from Germany, could not join us today due to a family emergency. And so now I have the honor of inviting Professor Rajiv Shah to share his key reflections on COVID-19 pandemic responses in Japan. Professor Shah is a professor in the Graduate School of Media and Governance at Japan's Keio University. He is also a senior fellow at the Institute of Global Environmental Strategies, Japan, and chairperson of SEEDS Asia and CWC Japan, two Japanese NGOs. He is also the chair of the United Nations Scientific and Technical Advisory Group for Disaster Risk Reduction and the co-chair of the Asia Science Technology Academic Advisory Group. Professor Shaw is the editor of a book series on disaster risk reduction published by Springer and has published more than 45 books and over 300 academic papers in book chapters so far. It is a privilege to have Professor Shaw to speak about the Japanese experience in tackling COVID-19. Thank you very much. Over to you.
Thank you. Thank you very much, Ali. Thank you all for inviting. And I personally am learning a lot actually by listening to the first two speakers. So thank you very much for providing this great opportunity. I think what Peter has just stated in his last sentence, like the information, trust, leadership, political commitment, possibly I would like to touch some of those issues in my presentation with the Japanese perspective. So hope you can see the screen and
yeah, it's visible. You can see it.
Yes. So before I enter into the COVID situation, let me just put a few context, which is possibly quite unique to Japan. Number one is its close proximity to China. I also didn't know, but later I heard that there were daily 7 flights actually directly between Wuhan to Tokyo. There were flights between Wuhan to other parts of Japan, other cities in Japan, but there were 7 direct flights. So you can imagine the air volume these two countries were having. Japan, many of you possibly know, has a very high aged population, 29% more than 65-year-old. And these particular photos are quite famous. If you just Google the urban density and the crowded public transport, so Japan is possibly stands very high on both of that. But apart from that issue on the population, demography, and all these things, there are also some legal or the governance aspect that Japan's constitution does not permit a forced lockdown. There is a long history of this pandemic, the health-related issue, and the governance mechanism, which actually prohibits the government to have a forced lockdown. But by saying that, the Prime Minister can make an announcement of an emergency, and when he or she makes an announcement of an emergency, so that gives a specific power to the governor to appeal to the people. Again, I highlight to appeal to the people to stay in home, but the governor cannot forcibly close any shops or forcibly close any roads or transports and all these things. But it can acquire actually some emergency life-saving drugs, some equipments, and so on. So that actually makes lots of, I will come back to this issue, and this is also linked to the people's attitude, and people's behavior actually becomes very, very important when you don't have a forced lockdown mechanism, how you stop the flow of the people. And then the vaccine complexity, I will come back to this issue at the end, that we have several legal obstacles and bitter past history of the vaccine. So it's quite complex process, and it's very, very time consuming to introduce any new vaccine in Japan. So with this particular context, now let's look at what Japan's numbers were. So this was yesterday's data actually. So total cases so far were 800,000, recovery 766,000. Total death was 14,730 with a population of 126 million. So I don't know how to interpret this data. When I show this to my overseas colleagues, they say, wow, this is an incredible achievement. But when this number like within Japan. So there are lots of criticism and every day lots of TV debates that how still we can have 14,000 deaths while China has only 3,500 or 3,600 deaths. So I keep that particular thing a little bit aside. So far, we had 4 waves, and you can see very clearly actually the 4 waves. The first case actually was reported in Japan on January 16th last year. So you can imagine, and this is again, I emphasized earlier, this very strong air connection between Wuhan and many other cities in Japan. And first case without travel history, which was reported in Japan, was January 28. So that is quite in an early stage before this pandemic was announced global, that before it was by WHO, before WHO announced this as a global pandemic. So, so that's the current Japan cases in numbers. And in case of vaccine, so far, this is again till yesterday. No, it was until June 30, so day before yesterday. So 44 million vaccine doses, 15 million fully vaccinated, which accounts to around 12% of the population. And first dose, more than 27% of the population. And again, as I mentioned earlier, that the Japan's approval process, it really takes time. Like many times it happens that if you have the overseas vaccines, and if those were tested on Japanese national overseas, so sometimes the countries accept. But for Japan, it has to be tested in Japan and with Japanese nationals. So that actually makes this whole process quite like slow, and there are lots of cautions and all these things. So you can see actually the starting of this whole curve means it's actually quite middle to late March when the vaccination started, and vaccination started with the health worker. So the frontline health worker, they got the vaccine at this late stage, when I think by March, most of the US, Canada, or most of the European countries, Israel, they had already done quite a high progress in the vaccine. So vaccine is a very, very cautious step in Japan. Now, what happened like in this whole process, I would like to point out a few important things. One is that to set up a high-level expert group, and this I say that this is to challenge the infodemic through science-based governance. As we all understand that there has been so much of noise, so much of fake news, so much of confusion. So you don't know whom to believe, whom not to believe. And for Japan, we had during the 2011 East Japan earthquake and tsunami, and following the nuclear meltdown, there were lots of this type of infodemic which happened, and there was a major breaking of the trust between the government and the people. So learning from that bitter experience and learning from some of the previous experience of SARS and MERS, especially again, the Taiwan and Hong Kong, which were mostly affected in SARS and MERS, is also very well connected with Japan, with lots of air travel. So with those experiences, as early as 14th of February, under a cabinet decision, this expert group was formed. And it consists of infectious disease expert, public health expert, virology expert, and lawyer, especially to see the legal provision. And it was, more importantly, it was supporting by a working group who has these data scientists, logistics experts, AI specialists, and so on. So I fully agree with what Peter has just pointed out, that it's not only just the public health issue, but it's more than that, like the surrounding issues and how all these different issues or different disciplines or different expertise actually support this public health thing. So there were lots of simulation exercise, future scenario creation. And one very important thing is that there was a regular press briefing jointly by the minister and head of expert group, and periodic jointly by the prime minister and the head of expert group. And why I emphasize about this jointly is that many times we see that, yes, when Donald Trump was talking, the head of the CDC was there, but a little bit on the back, and there are lots of photographs with different types of facial gestures and so on. But here, I think, again, learning from our bitter past experience of this nuclear meltdown or MERS and SARS, like both the head of the government and head of so-called, I say, the science part. So both of them were equally in the front, and they were making always a joint press briefing. And that, I think, was a very important new thing, which we did not see actually in the previous experiences. So to me, like, that was very, very effective. Of course, I don't say that there was no confusion, and there have been confusion, there are noises, there are criticism, but I think it at least helped in making it a little bit down. Then Japan's border control measure. So because of this very high proximity and aged population, urban density, I think this border control at the initial stage really helped to what we call the lowering down the peak and giving the health system little bit of time to prepare themselves, whether it is the ICU, whether it is some other emergency health equipments and so on. So there was this COVID ward which were created in the hospitals. There were some of the even hotels which have been booked by the local government, so that some of the lower symptom people who don't need to go to the hospital, but they need an isolation. And you know that Japanese houses are too small to have your own private space or like that. So so they prefer actually to have, if you are infected, so prefer to be in the and if you have lower symptom, maybe prefer to be in the hotel. So those type of things were actually prepared, and that this resilience of this health system, and that was very, very important, that how you build the resilience of the health system to initially reduce that peak. I think that worked very well. The cluster-based approach, and that was very strongly used by Japan. So it was like more retrospective tracing, and try to be more like one is more proactive, but also the retrospective tracing. And that really helped quite a bit to stop some of the clusters at the initial stage. And there were the 3C principles: the closed spaces, crowded spaces, and close contact setting. So these were highlighted at the very beginning, as a list of don'ts. And these were broadcasted in the TV, and like this type of posters you can see. I mean, this is, I'm showing it in English, but of course there are the original posters are in Japanese, and you see everywhere, even in the trains, in the public spaces and so on. So that awareness raising, when at the initial stage, when we still don't understand the nature of the virus, when there were lots of confusion, and when this whole infodemic issues were started. So some of these issues, this awareness raising, confidence building, joint press briefing, these were possibly very, very effective. This was also another very new, interesting way of alerting people, like drawing public attention. So they set up some numbers. Say, for example, what you are seeing on the left-hand side is the Tokyo Metropolitan Government building. So they have this color coding, and they set up some numbers that if the daily numbers goes above 500, with a 20 million population I'm talking about. So with the 20 million population, if the daily number goes above 500, then you see the red alert. These are some of the landmark bridge. So we call the Bay Bridge, which connects connecting the neighboring city, Yokohama and Tokyo. So they also use like this type of color, like blue color means that there is not an high alert, so it is under control and so on. So when it have a high alert, so it turns into red. So this type of, I'm just giving some of the examples. So the main message here is that how you make people little bit more, because not always people are reading the number, not always everybody is listening to the TV, but when they are outside, just to make them a little bit aware that yes, we are still in the high risk time, or whether maybe certain level of cautions needs to be done. So that type of citizen involvement was very, very important. And another important issues were this fiscal boosting, and which were like our analysis in this particular paper was like, this was the synergies between the new fiscal boosting, but also the existing development scheme. And if you see the numbers, so Japan's fiscal boosting was almost 42% of the national GDP, which is a significant amount compared to many other countries. But the important part is that Japan could mobilize because they had already existing these three major national programs. One is the Society 5.0, which is a futuristic society vision, then the National Resilience Plan, and the local SDGs, the implementation of the SDGs at the local government. So all three, there were like, these were more the development programs which were ongoing. And all this started after the 2015, after the SDGs were incorporated, after the Sendai framework for disaster risk reduction were incorporated. So, so all the fiscal boosting were actually injected into these three major plans, and we try to analyze in this particular paper that the main governance mechanism to absorb, like fiscal boosting number is okay, but if you don't have a proper governance mechanism to absorb that extra money which is coming up, you can't spend it within that time, and you can't actually, like the main reason is that how quickly you can spend that amount and how you can actually make like cover up the job losses or the livelihood losses which has been there during the COVID-19, the peak period like that. This particular paper, actually, we try to, these two papers, we try to analyze. One was the COVID-19 pandemic response on the right-hand side, like what talks about what is the initial, how it was the initial flattening of the curve. I mentioned some parts of this in the previous slide. And the left-hand side paper was a comparative analysis of East Asia. So it was China, Korea, and Japan, especially on three aspects: governance, technology, and citizen behavior. And we found that, of course, the different types of governance responses and the science-based governance responses. So whatever the decision you take, it has to have a proper logic, it has to have a proper data scenario, it has to have a proper data scenario projection. So that type of government response was really, really helpful. Some of the issues which are rooted in the culture, say for example, like now I was born in India, but now I live in Japan more than half of my life. And what I'm seeing here in Japan, like say for example, maybe November, December, January, February. This is the time is the regular influenza season in Japan. And almost 60 to 70% of the people, whether they have influenza, I'm talking about the regular influenza, whether they have influenza or no influenza, they always wear masks. So the mask culture has been very, very like natural in Japan. So, and also during the during that influenza season, like there have been very strict education right from the elementary education about the importance of your hand washing. So you will see if you go to an elementary school and there are this hand washing places, and you will see that step number 1, step number 2, how you do and how every part of your hand should be cleaned properly. So that type of education comes from the elementary level, and it becomes, when it comes from the elementary level, so over a period of time it becomes part of your culture. So that actually helped really the cultural part. And of course, the basic sanitation, the basic healthcare system. Japan possibly has the largest number of CT scan, even in the the health center or the clinic if you go. So there are the CT scans. So before you go to the PCR testing, usually we do the CT scan. So there have been lots of criticism in Japan that the PCR testing has not been enough and all these things. So I will come back to this issue a little bit later, but I think the basic healthcare system actually really helped. Food habits, you can always argue on that, but we made some interesting analysis on this particular paper. So if you are interested, you can have a look at that. I love Japanese food very much. So and then last year, what happened that we had 2 major flooding, 3 typhoon, 1 earthquake, and 1 volcanic eruption. So, and Japan is known for, it's a land of disasters, natural hazards. So during this pandemic, but it was a new experience actually, and I personally visited many of these affected areas. So how you manage the evacuation center, how you manage the volunteers to clear about the debris and the post-disaster debris and so on. So there were lots of new learning for that, and that's what we call the adaptive governance and addressing this type of cascading or compounding risk. So hopefully this year, like from yesterday to today, we are having heavy rain, and already there are reports of some parts of Japan has already flooding. So hopefully that this year the situation is a little bit better and we are more prepared. Now the evacuation centers are more prepared to make a proper distance, the social distancing, and then proper checking of the temperature, the PCR testing, and so on. So bringing last year's experience, we know that there will be seasonal disasters. And it's everywhere, even in India. Last year we had the typhoon. This year we had the typhoon, we call cyclone, and different parts of the flooding. So I think the learning lessons and bringing it for the new governance system, I think that's this adaptive governance part is very important. So this is possibly my last slide here, that I don't say that there are definitely positive parts of Japan's response, that in spite of the no lockdown, the number of infection and more importantly, the number of death was rather controlled. And again, I mentioned at the beginning that by constitution, you cannot have the lockdown. So, and you can appeal, but it is up to the people. So the important part here is that the citizen behavior becomes very, very important, but citizen will behave if you give them the right information at the right time, and the people have the trust in that information. And that's why that earlier point that the Prime Minister and the head of the expert group jointly coming in front of the TV or in front of the press and giving the joint statement, and there are questions sometimes addressed to the Prime Minister, there are questions sometimes addressed to the head of the expert group. So that type of transparent information and the trusted information is very, very important. Basic healthcare system is definitely a big asset Japan had. Expert group I mentioned, and people attitude. But of course, there are challenges. There are loopholes at every country's response. So yes, PCR test, less PCR test. That has been a major criticism. Many actually big companies like the IT companies and many like the Toyotas and Toyota Nissan, like the car companies. So they actually were very much willing initially last year to help to make the capacity in different way, but it was not approved medically. So it's a very complex dynamics there. Then tug of war between always the medical professional and the business lobby. We will be having the Olympic in next 3 weeks. The Tokyo's number is increasing compared to the last week for consecutive 8 days now. So because now the emergency is lifted, people are on the street, they are back to the office, or they are back to the pubs, restaurants, and so on. The business lobby have been actually strongly urging for that, but then the medical professionals, like this is a very, I'm sure that this exists in most of the countries. There have been lots of unemployment, loss of employment because of this extension of the Olympic, number one, and of course, the COVID situation. And another thing actually I want to highlight here, that when we made this comparison between China, Korea, and Japan, our lessons was that the use of emerging technologies, the new technologies, whether it is IoT, AI, big data analysis, China and Korea was much ahead than Japan. And again, the main reason is the Japan's cautious effort. Like there are technologies, of course, there are technologies, but between bringing the technology to application, there is a governance mechanism. So that governance wall is sometimes too thick in Japan, and that has also been a major area of criticism, which possibly we need to think about in future if we think about the society 5.0 or a super smart society. So there have been quite a bit of, we are still within the pandemic. We will see that how the Olympic is done, what are the new lessons coming up. So very much look forward for that. But I think I will stop here for the time being. And thank you very much for your patience listening.
Thank you so much, Professor Shaw, for a very nuanced presentation and highlighting several lessons for India. Not just vis-a-vis the infodemic approach to tackling the infodemic, but also undertaking very deep reform measures like education, basic education, and other steps that will be considered by India. Because if you have invested in your human capacities, there is less need for more draconian measures like the lockdowns, etc. So clearly very important lessons for India. Thank you so much for your presentation. I now have the honor of inviting Dr. Praveen Kumar Pathak to share his views on the underlying characteristics that drive vulnerabilities related to COVID-19 and what can India do to mitigate the impact of the COVID-19 pandemic. Professor Pathak currently teaches in the Geography Department of Jamia Millia Islamia in Delhi. He has previously taught at the Delhi School of Economics, University of Pune, Shivaji University in Kolhapur, and the Ravenshaw University in Cuttack. Professor Pathak has also been a visiting scholar at the Vienna Institute of Demography, Harvard, and Ohio State Universities in the US. Professor Pathak will examine subnational patterns related to COVID-19 confirmed cases, recoveries, and deaths in India from March 2020 to June 2021, which is the last month, as part of his presentation. Drawing upon secondary data from demographic, socioeconomic, and public health resources, he will highlight the vulnerabilities related to the COVID-19 pandemic across Indian states and union territories, and will discuss state-specific vulnerabilities and mitigation strategies that need to be considered. So over to you, Professor Pathak now.
Thank you, Dr. Ali Mehdi. I want to thank ICRIER, CAS for giving this wonderful opportunity to be part of this distinguished panel and share some of my thoughts related to the COVID-19 situation in India over past 15 to 16 months. Let me try to share my screen. I hope it is visible. Dr. Ali, is it visible?
Yeah, we can see it. We can see it. Thank you.
Okay. Thank you so much. So I think after hearing to such an august panel, I think we have learned a lot from experiences in Japan to UK and also India's health system performance in the last 15 months. So there are many important lessons that we have learned, and what I'm going to do in the next 15 to 20 minutes is just quickly walk through the progress of COVID pandemic in India and look at the spatial context within which the COVID-19 is actually unfolded. I was very much fascinated by Dr. Rajiv when he was talking about Japanese context, and he was referring to the idea of, how inculcating the disaster preparedness at the elementary school level is so very critical for preparing citizens, common citizens, to face different kinds of disasters. Of course, we know that Japan is a land with a very difficult geography, and people have developed over the course of time capacities and resilience to face these challenges. Now, if you think about public health, or if you think about health, is basically a social commodity. So social commodity means health is just not only individual individual outcome, but it is also a social outcome. So basically, I'm saying that if you look at this community context, or if you look at the spatial context, so the nature of the built environment, so what kind of housing facilities people have, what kind of sanitation or toilet facilities people have. Similarly, this is the health system in the given context, spatial context, So whether you have basic health facilities in the area, you have middle level healthcare facilities in the area, you have super speciality in the given geographical area. So likewise, different kinds of health behaviors that people usually practice. So for example, in India, we have a common tendency where people usually take common health problems and they basically are not very serious about it until and unless things become very critical and they have to take the concerned person to the health facility. So by and large, if I may say that the health literacy per se in the context of India in major part of the country, so the sensitivity, for example, if I talk about, the risk, if you think about, perception of getting infected with the coronavirus, if you talk to 10 persons, right? So I don't have a data, but I mean, I have a strong belief that, not many people would feel that they have a really high risk. So therefore, even after first wave or the second wave, we have recently seen the devastating impact of the second wave in India during April and May, even in June. But as soon as these, the lockdowns have been, we are unlocking in a staggered manner, we see like in Delhi NCR and other part of the country, that now people really not very keen to obey or follow the COVID appropriate behavior, whether it is, practicing using masks or social distancing norms. So there are many such behaviors which actually comprise the response of a local geography whenever you are exposed to different disasters. Now, we are living in a world where disasters are now, or different forms of disasters are now becoming, a part of life. So if you think about India, and given the diversity of geography, the diversity of people that we have in India, I think it is very important, drawing from the experience of Japan, how can we inculcate the positive health promoting behaviors among school children, because it is from there where we can actually bring a change. So I'm just quickly going to take you through the journey in the last 15 months and try to bring out some of the spatial context of how this COVID pandemic has actually impacted different states differently, and drawing upon the expert from experiences from England, where he was emphasizing that how COVID-19 has actually exacerbated the health inequalities and vulnerabilities. Because if you look at different geographies, all areas, if they're exposed to a given disaster or any calamity or a pandemic, the responses are different. The impacts are different, and the reason is because the local built environment, the local demographic structure, the local socioeconomic composition of the area, and at the same time, the local health system performance are different. So how these different elements together determine the impacts and the mitigation strategy is an important question, which is, I mean, people from a spatial perspective have a particular interest to look into that. So if you look at like where India stands today, so if you see, the red map actually shows the confirmed burden of cases in India. So we have more than 30 million confirmed cases of COVID-19 during last 15 months. And majority of this cluster, if you can see here, is mostly this major city center in the country. So whether that is Mumbai in the western part of the country, whether it is Tamil Nadu or Kerala on the south part of the country, or Delhi NCR and some pocket in the eastern part of the country. But beyond that, we also see a lot of bubbles across the greater plain of India and also in the northeastern part of the India. So basically saying that pandemic has actually taken its impact across India, right? And particularly the second wave, I will show you through some of the graphs that how the second wave was devastating and the geography of its impact was extensive. This green actually map shows you the recovery, so which is very consistent. And then we see the active cases. Today, we have around 500,000 active cases in India. More than 29.5 million cases have recovered. And we have close to 400,000 COVID deaths, which is an official estimate. And we know that from various other unofficial sources that these numbers are highly understated. Now, if you look at this graph, basically this graph is showing the overall trend of COVID confirmed cases in India between March 2020 to June 2021. Now, the blue graph is actually showing the monthly cases of COVID confirmed cases in India overall. And this orange graph is showing the cumulative sum of the total COVID cases in India. Now, we know that we had 2 waves till now in India of COVID-19. But if you look at these 2 waves, they are quite different from each other. For instance, if you look at the first 12 months of the COVID pandemic in India, the first wave actually had its impact mostly for the 5 months. And of the total 12.2 million cases that we had in the first year of COVID-19 in India, around 72% of these cases in the first year were actually coming from the first wave. So first wave, we had about 5 months, and we have seen actually 72% of the burden of COVID cases in the country. And if you remember when the COVID actually hit India in the early January, February, and when with March, government of India, when WHO declared as a global pandemic, and government of India started taking various restrictive measures with first staggered this thing lockdown, then all India lockdown, and then gradual unlocking of. So all these measures were actually implemented to buy time so that we can improve our system capacity, particularly public health response, to cater to the burgeoning number of COVID-19 cases and particularly the critical cases. So with the experience, I mean, one of our fellow panel speaker talked about the importance of history. What can we learn from the history? Now, if you talk the case of India, the first experience of the first wave of COVID-19, I think we did not learned our lessons well. And that was actually reflected because once this first wave was over, we saw that we had number of elections starting from Bihar, then Bengal, then the local body election in UP, and then there were various other religious congregations, and there were many other things which were happening. So probably I think common people in India, central government, state government, everybody started celebrating like life was actually going back to the some new normal. But after February 2021, we see that there is a rapid surge in the COVID-19 numbers to an extent that within a span of 2 to 3 months, India saw close to 16 million new cases of coronavirus. And then what happened, we all saw everywhere, there was huge toll that the country witnessed in terms of loss of valuable human lives and many other important things that all of us have seen and have felt and become part of. So if I look at this the bigger picture, that I think there was some degree of, I should say that maybe, a lack of preparedness, or we could not foresee based on the experiences of the first wave that probably we were not well prepared, or we were, even if there are a lot of criticism of various governments, in India, different state and union governments with regard to vaccination strategy, the vaccination Maitri program that we implemented, and a lot of criticism is being done whether we should have actually started vaccinating and given more stress on vaccination program. But even today, if you see like close to 25% of country's population, adults who are vaccinated, and we are now thinking whether third wave is going to hit us or how hard it is going to hit us, there is no clarity of thought about it. So I want to first also highlight here that we also lack, credible data systems, and particularly at smaller geographical levels to actually see what is happening. Because if you look at the numbers that we have, many of these numbers, are actually, of course, at the district level we have, but only these cases are there, and we don't know much beyond these cases, right? So the demographic, the socioeconomic, all these auxiliary information is missing. So I think we need to invest a lot more in creating credible data systems, not only for today, but thinking for future, whether there is any other kind of disaster that is going to affect India or different states in India. We need to build systems that can help us to understand and forecast different scenarios through which we can prepare, mitigation strategies. Now, if you look at this overall trend, so we see that, the second wave has almost 3 times higher impact of the total number of cases and deaths than the first wave. Now, this is a very interesting heat map where, what I'm trying to show is that during March 2020 to June 2021, in the last 15 to 16 months, if you look the top 10 states here, and I'm talking about the first wave of coronavirus between July 2020 to November 2020. Majority of the cases happen to be from these 10 states, which I'll just name for the audience: Kerala, Tamil Nadu, Maharashtra, Karnataka, Andhra Pradesh, which are relatively forward state in terms of their economic status, economic performance, demographic indicators, and health indicators. And there are few states from the eastern part of India, including Odisha, West Bengal, and Assam. So if you look at these 10 states, they together comprise about 44% of India's population as per the official projections of 2019. But interestingly, these states actually accounted for 70% of the COVID cases that happened during the first wave. So the point is that the first wave, when it hit India, its major focus was restricted to specific states. Of course, we can understand why this pattern actually happened, because most of these states have, very good, global networks of, commerce and business. A lot of people are moving. They have better air connectivity. They have trade routes. So therefore they have a huge exposure. And the corona, when it hit India, majority of the focus of in terms of geography was restricted to these states. Now, if you compare this with the second wave of COVID-19 that happened in 2021 between April to June. So here what we find is pretty interesting, that beyond these 10 states, we had other 7 states, for example, UP, Bihar, Rajasthan, Madhya Pradesh, which are not so advanced economically speaking. Means if you look at different economic indicators, demographic indicators, health system performance indicators, which are not very progressive, and they have been called as so-called Bimaru state by renowned demographer Ashish Bose. So if you look at these states, they comprise for about 44% of India's population, but they accounted for 25% of new coronavirus cases. So in addition to the first 10 states, these 7 states together, so these 17 states actually accounted for around 90% of COVID-19 cases. So here the point I want to bring home is that when you think about the second wave, not only did it came at a very restricted time period, because there was a very small response time for the state to respond. At the same time, the impact was so huge that the currents of the impact was felt across the states of the country, not only in economically and demographically advanced states, but also the states where you have a higher proportion of rural population, where you have a lot of interstate migrants. Maybe you can call them migrants who are returning from metropolitan cities and going back to smaller villages and towns. So here I want to just bring to a notice the fact that if you think about mitigation strategies, I think for India, it is important to understand at the micro geographical level, because we have more than 600,000 villages, more than 8,000 smaller cities and towns and metropolitan cities. And if we have to think about the response to disasters or pandemic, it is important to first understand these local geographies and create a database in such a way that we know that what kind of built up environment exists in these areas, what kind of health system exists in these areas, what is the the settlement pattern exists in these areas. Because if I talk about the top 10 states, majority of them have the bigger cities of India. So if I just talk based on my own experiences and what I've seen in recent few weeks. If there was any person in the household who was infected with coronavirus, for example, in city like Delhi or in Mumbai, which are so costly to either buy or rent a place, and you don't have enough space to live, and thinking about isolation, thinking about quarantining in such location is extremely difficult. Similarly, if I talk about Dharavi, one of the biggest slums in the world, look at the density of population of Dharavi. More than 3 lakh residents live on per square kilometer of area. So, I mean, thinking about implementing measures which are appropriate standard COVID protocols probably was not practically possible. So therefore, whenever we have to think about, similarly, if you think about, COVID appropriate behaviors in, for example, in western part of India, in Rajasthan, or in the northern part of the country, in the coastal areas, there are very difficult terrains, very difficult geographies. We were, I mean, if you think about availability of water, if you think about availability of sanitation facilities, I mean, there are large proportion of household in part of the country where less than 30 or 40% households have access to safe drinking water or sanitation facilities, or they have access to a good housing for themselves, right? So given these diversities or heterogeneities in terms of the geographies that we have in the country, if we have to think about building a response, and I'm not talking about building a response for short term, but if you're thinking about building a response for a long term, for a society, something like Japan, where even if there is any kind of calamity or disaster that strikes us, we have to inculcate through our students, through our college going students, schools, elementary schools, everywhere, create a program wherein we are trained to respond to such scenarios, right? So health promoting behaviors. So I think these are, so going forward, if you look at the trends of the COVID-19 related deaths in India. So if you see that we have more than 400,000 deaths over the past 15 months, and again you see that the second wave saw such a huge jump in the number of deaths that was very difficult to imagine, and probably our health system was never ever ready, or even our governments, our planners never foresee such a situation to prevail. I mean, Dr. Shakti was talking about the severity of the situation, where access to oxygen, access to medicines, finding a bed was the most expensive thing during such a huge crisis that we saw. So if you look at the daily toll in these 2 months, we have more than 4,000 deaths which were reported. And if you look at the geography of these deaths across the states in India, then again we see that in the first wave, these majority of deaths happen to be from a mixed group of states. For example, Maharashtra, Gujarat, Delhi, West Bengal, Madhya Pradesh, Uttar Pradesh, Tamil Nadu, across board, we had these deaths. So these top 10 states together actually comprise about 66% of India's population and 71% of COVID deaths during the first wave of COVID-19. In the second wave, which is the most devastating wave that we had, we saw that, again, the geography, because with the impact was so huge that we had the currents across different states. So not only was restricted to these top 10 states, but also many other states, for example, Karnataka, Punjab, Bihar, many other states was affected by the COVID deaths, and we all have seen the alarming and disturbing pictures across country where even getting a burial or a cremation was so very difficult. Now, if I have to make sense of such pandemics or disasters or such calamities, this has to be looked into through basic or fundamental underlying sources of inequalities, because people do not have access to equal resources. There are important markers of inequality in society, whether it is economic status, whether it is social status, whether by geographies, whether by your age, whether your sex. All these markers of social inequalities are underlying to explain the vulnerabilities that we have across Indian states and union territories. So I, along with my colleagues, have used data from various secondary sources which were available in India, including from census, from national representative surveys like National Family Health Survey, national sample surveys of various rounds on health profile, also looking at the quality of housing, the water facility that is available. We were also looking at the health system characteristics. So we were looking at socioeconomic deprivation of people in the states in India. We were looking at characteristics, for example, proportion of slum population, proportion of households which were crowded, multi-generational household, because there was a lot of scientific studies which said that the risk of transfusion of coronavirus was higher among households which were multi-generational. So we had this indicator, we had this interstate migrations, and we also had we constructed using factor analysis one indicator to understand the overall health system performance using number of population per primary health center, number of populations served as community health centers, number of A&M workers, hospital bed ratio. So all these health system indicators, demographic characteristics, and socioeconomic status of people were put together to generate an indicator of socioeconomic vulnerabilities at the state level and also at the union territory levels. And what we see is a very interesting that majority of this deprivation is actually concentrated in the northern and central region of India and part of the northeastern states. On the other hand, the southern and the western part of India and part of the north central India seems to be low or middle vulnerable from socioeconomic perspective. We also look at the epidemiological vulnerability across states. So basically saying that, the pre-existing diseases or comorbidities that people may have, and whether that was associated with the confirmed cases or deaths in the country. And this is how it looked like when you plot a map across India. So here we see that, the vulnerability seems to be quite, it's quite distinct. And here we find that again, central part of India and the northeastern has higher vulnerability, followed by the south and the western part of the country. And this is an interaction of the socioeconomic and epidemiological dimensions of vulnerabilities. And the composite map of socio-epidemiological vulnerability looks like this, where you find that the north central part of India has a very high socio-epidemiological vulnerability if you have a pandemic or any disasters to mitigate. We did some regression models. We used negative binomial regression models to understand the association of these characteristics, epidemiological, demographic, socioeconomic characteristics to explain, or to understand coronavirus cases in the country. And the bold variables are variables which was statistically significant. We find that, incidence of poverty had a very strong association with coronavirus cases. Households which have food insecurities. Similarly, households, where you do not have access to sanitation facilities or safe drinking water, or states where you have high interstate migration, states where you have high per capita health expenditure. So these are some of the factors which were very significant to explain, interstate heterogeneities in COVID confirmed cases. Also with comorbidities, we found that, percentage of people who had hypertension or with diabetes had a very strong association with COVID-19 confirmed cases in India. So what can we learn from this? That poor hygiene and sanitation facilities associated with COVID, poverty and food insecurity elevated the risk of coronavirus in the country. Urbanization and interstate migration has a strong bearing upon coronavirus cases, and comorbidities also appear to have elevated the risk of COVID cases in the country. We also did a model to understand the factors associated with COVID deaths. And here we find that, poor housing, overcrowding, and lack of sanitation facilities was linked with COVID diseases. I mean, of course, we can look at, the methodological or the data that we have may not be very robust or may not be very detailed, but whatever, basically we are able to draw some major patterns that how the urban, urban planning is critical, or provision of basic human needs is extremely critical if we have to avert such kind of pandemic or disaster in future. We have to build a space where we provide basic, decent living condition to people, so that if in future, if any such, God forbid, any situation comes, then people will be cushioned from such effects. Then, of course, multi-generational households and households where there was food security saw higher risk of corona deaths. Slum clusters, urban places, and interstate migrations also heightened the risk of COVID deaths. And comorbidities was also strongly associated with COVID deaths. So just to draw some points out of this discussion. So we know that there are important heterogeneities in the burden of corona in the country, but the magnitude and severity varied depending upon the underlying, socioeconomic and epidemiological vulnerabilities. And we saw that the COVID-19 cases were significantly associated with households which had poor hygiene and sanitation facilities, which were already economically poor to begin with and had food insecurity to begin with. And these were essentially places which are highly dense and also saw a lot of migration in and out. Comorbidities had a higher risk of coronavirus cases, and COVID death was concentrated among households where you have poor quality of housing, hygiene, and sanitation facilities. And multi-generational households were also associated with COVID deaths. And therefore, I think it's very high time that, role of public health institution is very critical. And one of the things that we have seen in the last 15 months is the issue of trust. In a country like India, which is predominantly rural, agrarian, majority of the workforce is working in unorganized sector where access to, Professor Shakti was talking about access to health insurance, and he rightly pointed out it, that majority of people have either no or very basic health insurance. And the cost of treating inpatient of COVID is so enormous. Last week, there was a report in the Times of India which said that of every 100 rupees that people spend out of pocket, the government was spending less than 1 rupee. So that is the degree of variation that is there with regard to seeking treatment of COVID in India. And therefore, it is very critical that we recognize that if you have to prepare for a society to meet any kind of exigent situation, whether it is pandemic, whether it is earthquake, it is tsunami, it is, we have to inculcate a healthy society. We have to inculcate a society which is not only literate, but also has health literacy. A society which believes not only in curative care, but also in health promoting and preventive care at the same time. Otherwise, if we cannot make these alarming and these stressful times to remind us of our responsibility as a common citizen, as a human being, then we are all together in this. Either we all can come out or we are all going to struggle together. And among them, of course, there are certain sections which have disproportionate vulnerabilities. For example, children in the last 15 months have never seen the schools. I have a small daughter, and there are many young children who would have loved to go to kindergarten and enjoyed what it feels like going to a kindergarten school. But for her lifetime, she will not going to see this kindergarten stage. We don't know when this corona is going to be over, but there are many such, there are many students with whom I interact on my classes, and I see them, their curiosity, their eagerness. They ask when the university is opening, when the college is going to open, because these young minds, these fertile minds, they just not only need academic atmosphere to learn, but also as a complete development of personality, it is very important that access to academic sphere is given. So, and similarly, elderly, if you see, a lot of social isolation has huge impact on mental health, and particularly among not only young and adults, but also on elderly population. So there is a special need of people that need to be met. Of course, a lot of people have lost their near and dear ones. They have also huge mental burden, and there is no way how can we address them, but we have to find some way, because life has to go on, and we need to come up with something so that we can, find support to all these young people who have lost their jobs, both men and women. How, I mean, Dr. Rajiv was talking about, he was comparing different states, and I was looking at India's figure very curiously, and I saw that India's GDP of the government support to rebuild better is 10% of our GDP in the last 12 months or so. And for a size and the diversity of country like India, we need lot more support. And because ultimately, the response, it is always the case that those who have, I think about Darwin's theory and the idea of survival for the fittest, and that's what we have seen. People with resources living in important locations, those who have good connections, they would always sail through. But if you're thinking about public health strategy, we have to think about geographies, we have to think about small villages, we have to think about remote villages, smaller cities, towns, and then metropolitan cities. Think about building information channels from bottom up, feedback mechanism from bottom up, so that not only do we have policies that is the outcome of the common man from the bottom level, so that this policy can really deliver the results. So with this word, I want to thank Ali, and it was really great, and I hope to see some feedback. Thank you so much.
Thank you so much, Professor Pathak, for a very insightful presentation, highlighting the heterogeneities, the vulnerabilities, especially at the local level in the context of India, a country which is so vast and huge and has so much diversity. And, a simple, drawing up of lessons from the international arena is not going to help. We also need to be very cautious about these vulnerabilities that we have in this country. I'm sorry we have completely run out of time, and but the glad part is that we can still see a substantial number of participants who are still there on this forum, which means the speakers have done a great job. So my thanks to them for for your time, for your very wonderful presentations today. And we will make sure that the questions that are there, we will pass it on to you. And if there are any responses, we will share it with the participants. So with these few words, may I ask Professor Alok Sheel if he wants to add something, or Mr. Rimmele if he wants to add something. Otherwise, we would.
No, Ali, I think we've had a very rich presentation and experiences of different countries, and been a big learning process, at least for me. And Peter might want to say something.
Yes, as well, a great learning process. And unfortunately, I find one of my statements of the opening confirmed that we tend not to learn from history. So you mentioned India as a sum. We know from history that pandemics always come in waves. It seems not to be recognized. India made the experience. Now Australia is the newest victim. They have done first. They're totally unprepared for a second wave. So we seem not to learn from it, one point. The other one, there was also discussion about, and several points, to improve public spending on the health sector. I totally agree, as it would support and increase the general health and benefit large proportions of the population, but we could not set up a rule by saying the higher the public spending is, the better we get through a pandemic. Take the US as a sample, where you have like 16% of GDP spending for public health, and they got through the whole pandemic as the worst ones, the biggest fatalities. So there seem to be other factors what overwhelm maybe that one. In the US, we could say that, of course, that during the Trump presidency, the acting, or rather the non-acting, was the decisive factor. But so the public spending is one big factor, but it would not count for it alone. Overall, great seminar, I think.
So with those words, so thank you everyone, for your time today. It was really fascinating to have these, these interactions and these points from all of you. So yeah, we wish you all of you, good health, and as well as for your families, and we look forward to meeting again. So thank you very much. Good evening, everyone. Bye-bye.
Bye.
Thank you.
Thank you, everyone.
Thanks, everyone, and bye.
Bye-bye.
Bye. Stay safe, everyone. Thank you.